A very good afternoon, all of you. So after the aesthetics and orbit session, now we are moving on to the next session, that is periocular trauma. And we have a galaxy of speakers. First, I would like to request the chairpersons to please come up on the dais. We have Dr. Rajesh Mazumdar Chaudhary, sir, as a chairperson of this session. Sir, may I request you to please come up on the dais? And also we have Dr. Senthil Nathan as a co-chair of the session. Yes. And as a keynote of the session, we have none other than Dr. Gangadhar Sundar. And I would request sir to also please come up on the dais to join the chairs. So the first talk of the session is by none other than Dr. Gangadhar Sundar sir, who is heading the Department of Oculoplasty and Orbital Facial Surgery at NUH Singapore. And sir needs no introduction. And he has been an authority in oculofacial trauma, and he is a well-known international faculty conducting so many international instruction courses on trauma all around the globe. So sir will be speaking on imaging in orbitofacial fractures. And we'd like to hear about it from you, sir. Over to you.
Thank you, Maya, and it's great to be back in India, this time in Kolkata. My only complaint is so far I've not been fed any mishti doi, so I'm looking forward to it in Kolkata. So those of you from Kolkata, you know now how to take care of me. So this is the first talk where I'm giving in a trauma session where imaging precedes clinical assessment, so on and so forth, and I'll try to do justice in the next 10 to 12 minutes or so. And this talk is going to be focusing purely on imaging. There's going to be another trauma session, I think, tomorrow, where we'll talk about some more recent advances and how we apply, including pitfalls of imaging itself. These are my disclosures. But there are a lot of these chapters that I've written exclusively on imaging and orbitofacial trauma, including the latest book by Dr. Guy Ben-Simon, and I'm happy to share a PDF copy of imaging in various traumatic situations. As long as wars exist, we're going to see trauma. And if you say in India there's no war, there's no war going on except in the border front, that's not true, because there's war going on in every school, every college, every university, every street, every factory. In other words, there's trauma everywhere. And there's a famous saying from the Second World War that war is the only proper training ground for a surgeon. And the take-home message is for leading institutions and leaders of institutions. If you train your trauma residents and fellows and residents well in trauma management, every other elective surgery management will become much better. And from that point of view, reading the scans that you request, not order, is very important. So why do we do imaging? We do it to confirm a diagnosis, this presumptive diagnosis. Apart from knowing that there was a fracture, you want to know the degree of displacement. We'll talk about how that plays a role in management. There are significant medico-legal implications, both at the work site, road traffic, factory, so on and so forth. And finally, we use a technology we use from the various forms of imaging, not just the films that patients bring, but the DICOM data, which is useful. For all practical purposes, CT scan is the imaging modality of choice. X-rays are out. The only reason for doing an X-ray is to screen for any metallic or radio-opaque foreign bodies prior to doing an MRI. And CT scan is not any old-fashioned CT scan. It's now done with an IGS protocol, Image Guidance Surgery Protocol, which has sub-millimeter cuts, 0.625 millimeter cuts, which are acquired in the axial format and then subsequently reformatted in the sagittal and coronal planes, which we look through your PACS viewer, not through your films, because films are compromised because of the number of sections they would do, and then finally you end up managing. What are we really looking for in scans is the placement of the rim, whether it's broken or not, the apex of the orbit, superior orbital fissure and the optic canal, and everything else in between. These two stars highlight the anterior, middle, and the posterior part of the floor of the orbit, which kind of tells you where in the orbit, anterior third of the orbit, middle third of the orbit, or posterior third of the orbit, is where the fracture is based on how you're going to be managing these patients. Traditional textbook talk about the floor as a straight line. It's not a straight line. This, and again, is something that you're looking for in scans. And when you do in the sagittal, you can see the image below. You're looking for the posterior ledge. And that is important because that's the ledge on which you're going to be placing your implant. So again, role of imaging and you seeing your CT scan, and we do not read reports. We read the scans ourselves. We also define this angle between the floor and the medial wall, what we call as the angle of inferomedial orbital strut. Perfect AIOS for AOS here. I think that was a keynote last year. So take that away. Raghu presented this at the ASOP press meeting. And we talked about this angle. And when you're talking about restoration of orbit of a combined floor medial wall fracture on one side, you measure this angle in your DICOM data, in your films, even using a protractor. That's how I started off. You pre-bend your implant, and then you replace the implant in the proper way, with or without navigation. You get good results. So this is literally Raghu are you here? No, the Raghu is there. So he literally plotted these images when we presented it over there. So these are all clinical applications of patients who have a floor or a medial floor and floor fracture. We are pre-bending an implant. We are not doing intraorbital manipulation, and you get good anatomical restoration of these patients, and it can validate it. So how do you read a scan? So reading scans and surgery is like religion. There are rituals, and you do not question the rituals. You do it a particular way because Dr. Santosh said it so, Dr. Usha said it so, Dr. Ashok Grover said it so, okay? You follow that. You don't cut corners and jump the hoop and just go on to managing the patients itself. So learn to be a student of the normal. So that's why when a patient is injured on one side, don't look at the scan on the affected side alone. Go to the normal side because there are numerous variations itself. So by default, we look at scans. You can see the scan bottom left over here looks like a medial wall fracture. I don't know if anybody else sees anything else. In the bottom left image, there's a straight line in the orbit. Remember, the human body does not have any straight lines. And anytime you see a straight line, there's probably something inside there. That's a Medpor implant inside the orbit, which sometimes are even missed by radiologists and ophthalmologists and orbital surgeons, believe it or not, okay? And these are all examples what you see. Here's a video which plays where we do a CT face and orbits. It's not just CT orbits that we do. Start off with the mandible, work your way up towards the maxilla. Remember, maxilla forms the floor of the orbit. You can see the disruption right over there. And the maxillary anterior wall and the lateral wall is broken. You can see the infraorbital canal is being broken over there. And the lateral part of the maxilla articulates with the zygoma. You can see the zygomatic arch broken. You can see the spheno-zygomatic bone suture also being displaced. Medial wall in this place is intact. Go down to the optic canal, and then you look at it. Likewise, once you review the axial scan, you want to look at the coronal scan. Remember, the nasal bone is the most common bone to be broken, following which is a typical ZMC fracture. Here's a typical ZMC fracture. You can see the disruption of the articulation of the frontozygomatic and the zygomatic-maxillary suture involved. And then if you go further behind, the zygomatic arch is also involved. Again, you want to be able to study all the way to front to back. And finally, the sagittal cut. That gives you the length of extent of the floor, which is most common, and sometimes a roof. And that gives you can see the slight convexity of the posterior bulge, infraorbital nerve running down along within the sinus itself. And then when you go to the other side, here I am pausing at the nasolacrimal duct over here, which sometimes also is broken, and you want to look at it. And then you go to the opposite side. So learn to be a student of the normal. See the normal scan first before you go to the abnormal side. And here you can see the disruption of the floor. You can see the palatine bone, which is the posterior ledge. That tells you the degree of displacement. It tells you how far from the rim the fracture ends. So then you can pre-bend your implant, pre-place your implant, and reconstruct the orbit. So reading the scan is extremely important before you go ahead evaluating and repairing these patients. So also important to keep in mind is, yes, when there's an obvious disruption of the cortical bone, it's very easy to diagnose a fracture. So you are all not just ophthalmologists. We are not ophthalmologists. We are orbital surgeons. We are slightly different species. I think that's what Fairuz is trying to tell us all, right? Ophthalmologists are different, orbital surgeons are different. We are different animal species. So you have to be held to a higher standard. You want to pick up the subtle signs of fractures, pneumo-orbit, air in the orbit, air in the anterior skull base and cranial fossa. These are all signs as a disruption of the frontal sinus, ethmoid sinus, maxillary sinuses. Distortion of extraocular muscles. These are all subtle signs because with very minimal displacement, you should be able to pick up fractures. So with all this basis, we came up with a practical classification of fractures along with patient-specific modifiers, a lot based on radiology. So we classified fractures into simple or pure orbital fractures, which is what we all manage. But sadly, this accounts for only 20 to 25% of all orbital fractures. 75% of orbital fractures are complex fractures, which involves the ZMCs, the NOEs, the Lefort 2 and Lefort 3 type fractures, the cranio-orbital fractures, the skull-base fractures, And finally, the rare panfacial fractures, everything from top to bottom. You have to have a classification. Without classification, you cannot plan your management. You cannot decide whether you're going to fix it alone or with your craniomaxillofacial surgeon, with or without a neurosurgeon standby, and so on and so forth, okay? So that's where the classification comes in, and that's all based on scans. So here's an example of a pure internal medial wall floor fracture right over here with herniation of contents. Remember, it's not entrapment. Entrapment is a clinical sign. Herniation is a radiological sign, as opposed to a complex fracture you can see on the image right, where you obviously a neurosurgeon has to be involved in addition to you when you're going to refix the orbits. Examples are two forms of blowout fractures. Remember, floor is the most common, but you can see the combined floor and medial wall fractures, which is far more challenges. In fact, most surgeons, even expert surgeons, have great pitfalls in managing a combined floor and medial wall fractures. That's why the AIOS came in. The second most common fracture of the facial skeleton, the ZMC fractures. Again, I have ophthalmologists who come and tell me, my cousin broke his face, he's got a ZMC fracture, but no ophthalmic involvement. How is that possible? Unless you have an isolated zygomatic arch fracture. So all ZMC fractures involving the body involve the orbit, and I think we should be involved in managing these patients. Here's an example of a patient, right? You can see literally a shattered orbit, and it's not just a shattered orbit, shattered soft tissue, but it's no point putting the lacerations alone together, but you bring your sequential approach, roof, lateral wall, inferior rim, then the floor and the medial wall reconstruction based on the reading of the scans. You get your zygoma right. Once you get the zygoma right, you get the inferior rim right, then you pre-bend your titanium plate or whatever plate, PSI, whatever you want, and then you do a soft tissue reconstruction, you can get good results. A quick take-home message in the next minute or so about nasoethmoidal fractures. Again, this is relevant to ophthalmologists because the NLD is involved in 7 to 15% of mid-facial fractures. So again, you want to be proactive about it rather than wait for a dacryocystitis and do a DCR. With all the hardware there, we do prophylactic intubation for these patients. And finally, cranioorbital and panfacial fractures, where we sequence reconstruction itself. So I'll just quickly move on to the last couple of slides about postoperative imaging of orbital fractures. These are implants right over there. These are examples of lacrimal system involvement. Again, you do not want to be the person just looking at the floor, medial wall, lateral wall, and the apex of the orbit. You want to look at the disruption of the lacrimal drainage system, do prophylactic intubation. Traumatic optic neuropathy, as you know, again, is a clinical diagnosis, not a radiological diagnosis. And finally, let's stop with this postoperative imaging of fractures. Which refractive surgeons offer refractive surgery and does not do a postoperative refraction? If you do a refractive cataract surgery, multifocal lenses, premium lenses, who does not do a postoperative refraction? Why are we ophthalmologists sticking implants inside the orbit, hoping it's in the right place, thinking it's in the right place, and actually they don't want to see the implant in the wrong place? So get into the habit of doing postoperative imaging of orbital fractures, and I think I'll stop right there and go on to more recent advances in Dr. Grover's course, which is going to be held tomorrow. Thank you very much.
Thank you so much, Dr. Ganga, for that elaborated talk, and definitely understanding the imaging plays a very crucial role before planning your orbital reconstruction. And we'll have the panel discussion towards the end of the session when all the aspects of the trauma are covered. So next, I invite Dr. Raghuraj Hegde on his talk on orbitofacial fracture, 10 commandments. He is a very well-known oculoplastic surgeon in Bangalore, associated with KIMS Bangalore and Manipal hospitals. So over to you, Dr. Raghuraj.
Yeah, thanks Maya. Thanks Dr. Fairuz for making me part of this session. I'll be speaking about 10 commandments, and some of the commandments have already been reinforced by Dr. Ganga. So thank you for that. So I have about 8 minutes to finish 10 commandments, so I'll try my best. So the first commandment is thou shalt know your anatomy. So as oculoplastic surgeons, as orbital surgeons, we need to know anatomy very well to be better than the other specialties who are treating the orbit fractures. So there are three horizontal buttresses and as well as 4 vertical buttresses, which which is basically the support system of the orbit. And the most important intraorbital structures are for orbital trauma are infraorbital strut, that is the inferior orbital fissure, that is there in the green arrow, and orbital strut or the intraorbital buttress, that is red arrow, and the posterior ledge marked by the blue arrow. So you can see that the inferior orbital fissure is increased in size. So that's indicative of that the pressure on the fracture is a very large one, which is disrupted the posterior orbit as well. And in this, the orbital strut or the intraorbital buttress is fractured. So this requires an implant which will have to reconstruct the intraorbital buttress as well. And the posterior ledge, which is the blue thing, that is where we usually put the orbital implant. So anatomy is important for surgical technique as well. While we do a transconjunctival technique, we need to know the planes where we are going, where we need to avoid the fat from getting into the surgical field. So I usually use a transconjunctival, pretarsal, subtarsal, preseptal approach, so that the orbital fat is not in the entry. So this is usually the swinging eyelid approach that we use to expose the floor of the orbit. So commandment 2 is basically thou shall know your anatomy. Orbital radiology. So orbital imaging, and there is preoperative, intraoperative in conical and navigation surgery, as well as post-operative imaging and use of imaging in patient-specific implants that I will not cover on this. Nowadays, CT scan, we need to order it in a specific way so that we get the maximum information. Now we get scanners which have 0.625 mm. We don't need films for all of these. We can get it in a CD or a DVD format. The DICOM data can be put, and we can see it in our own we can use a softwares to see these images. So there are some free softwares to read these DICOM data for Windows as well as Mac OS. Commandment 3 is basically thou shall always choose the right implant. So there are the ideal implant is there are various ways why we use a particular implant. Many of them, many times it's because of the cost, but stability, fixation, how it behaves post the surgery is also important. Many implants are there, and we always need to know which implants to use and in what situation, whether large fractures, small fractures in pediatric. So we should not be fixated on single implant. We should always know which implants to use. The commandment 4 is thou shalt not be fooled by a white eye. So this patient came to me with a perfectly white eye, and even on the 9 cardinal gaze, there was no restriction of eye movements. But when we do but she was symptomatic. She was having double vision in up gaze. So this is what showed that there was a fracture in the orbit. There's a trapdoor fracture with entrapment of the intermuscular septae. So that is what was causing her double vision. So sure enough, when we went in, we saw that there was a crack in the floor of the orbit, and we repaired it with a bioresorbable implant to close it. So pediatric, again, this is a pediatric orbital, again a white-eyed orbital fracture, which was a fracture that we could see on imaging, and we treated it with a bioresorbable implant again. And always thou shall always mind the posterior ledge. So the posterior ledge that I was talking about in the previous slides. So this is the posterior ledge. This is the palatine bone where we actually have to put the implant. In many cases that we see post-op done elsewhere, we see that the implant is not sitting at the posterior ledge. So this is the case, floor and medial wall fracture, and we repaired it with a combined prefabricated anatomical implant. So this you can see that there is it's sitting on the posterior ledge nicely, and this is what this is after 6 weeks. So this is what improves the inophthalmos. Otherwise, the patient will have a post-operative inophthalmos. Commandment 6 is thou should always look for orbital fracture in any facial fracture. So most of the ZMC fracture, like Dr. Ganga said, involves the orbit. So about 30-40% of facial fractures involves the orbit. So you should always look for the orbital fracture in any fracture. So it should go through you before you say there is no orbital fracture. So in ZMC fracture, often the orbital floor is involved, the lateral wall of the orbit is involved. So ZMC fracture, we do a 3-point fixation, but sometimes even after a 3-point fixation, there is sometimes a gap in the floor of the orbit. This is what we have to be very attentive about, and whenever there is a ZMC fracture, oculoplastic surgeon should be part of the team, which is repairing these fractures. So commandment 7 is thou shall ignore soft tissue injuries at your own peril. So we often get very complex trauma where we don't have landmarks to work with, and there is no bony landmark as well. So first we always fix the bony orbit, and bony face. The bone reconstruction has to be correct, and only then on top of that you can do a soft tissue repair. If we don't do this in the primary setting, many of the ends go into necrosis, and then we don't get a very good post-operative outcome because the vascularity and everything will be compromised at a later stage. Commandment 8, thou shall always love thy neighbor. So oculoplasty is a unique subspecialty where we are in constant contact with all the many subspecialties in other specialties. So we have, just to demonstrate it, this is a nasolateral fracture that we had bilateral orbital fractures, frontal bone fractures, and a dural leak as well with the CSF leak. And the neurosurgeons got to work on did a craniotomy, fix the orbital fractures. We fixed the dural leak, and then after that we got to work with the maxillofacial surgeon and myself, and then we fixed both the orbits. And once we did the fixed orbit, the nose was fixed with cast with POP plaster. And this is the post-operative scans where we see that most of it is well reconstructed, and this is the 3D reconstruction, and this is about 2 weeks post-surgery, and this is about 1 year after the surgery. So thou shalt not steal and thou shalt not commit murder. So we often have other specialties attempting to do our surgeries, that is the orbit surgeries, and this is one such case where there was a floor implant used in the roof of the orbit. I think I have just 1 more minute thing. So floor implant was used on the roof of the orbit, and it's going right through the superior rectus. And not only that, it was even hitting the macula. So we can see that edge of the implant making indentation on the macula. So another case where the floor implant is right between the inferior rectus and the globe. It just missed the globe by a few millimeters. So these are all things that can happen when you don't follow the principles of the fracture management. Another case where, regardless of the bad reconstruction of the right orbit, there is also a plate on the nasolacrimal duct itself, which caused the secondary acquired nasolacrimal obstruction. And the last commandment is thou shalt always order a post-operative CT scan. And I think Dr. Ganga also mentioned that. And so basically, so it's always good for a feedback for the surgeon as well. When in this particular case where I wanted to have the implant a little bit more medially, I would have liked it better. So, but it's always a learning curve for the next case when we know that where do we need to put the implant. And also, it also gives a feedback to the patient as well when we've operated. Here, we've put a patient-specific implant, and when we have a post-operative image, it gives the reassurance to the patient as that their problem is resolved and what we are doing for the patient. It's easier for the patient to understand what has been done for them. Thank you.
Thank you so much, Dr. Raghu, for those interesting cases and the 10 commandments. So just a quick comment from Dr. Rajesh.
Thank you, Dr. Maya. We had two relevant and impactful talks, just one after the other. I must say that there are a lot of things to learn. From Dr. Sundar's talk, what is so important for all the trainees here, and for all of us actually, that get into the habit of seeing normal scans regularly, because that's how you learn how to pick up abnormal scans. Challenge yourself and your radiologist to ensure that you have actually got to the bottom of the problem and not just rely on their reports. And post-op scans, as Dr. Raghu and Dr. Sundar both said, are very important. For Raghu's talk, I'll say two things. One is soft tissue management is of premier importance. You have seen a lot of complications arising from, say, I wouldn't really be unkind, but maxillofacial surgeons, when they do orbital fracture repair, they're not so much aware like us how to deal with soft tissues, so sometimes they get issues. And also the posterior ledge, keep that in mind while repairing orbital blowout fracture.
Thank you, Dr. Rajesh. So next we have Dr. Grover. He needs no introduction. Sir is a Padma Shri awardee. He is a chairman at Sir Gangaram Hospital at the Department of Ophthalmology and also at Vision Eye Center. He has been a past president of AIOS, OPAI, ASOPRAS, and he has been associated with many educational society, including ICO. He has been a teacher of teachers and an inspiration to all of us. So, sir will be speaking on orbital wall defects, patient-specific implant. Over to you, sir.
Thank you, Maya. The earlier two talks have set the stage with diagnosis, principles of management. We'll talk about a specific scenario, and then Senthil will take care of our complications. Thank you, Scientific Committee, for this concept of a subspecialty day, and Fairuz for inviting us to this session. So there have been a number of realizations and developments which have made a huge difference to the management of orbital fractures, improved diagnostics, improved trends, improved implants, and improved imaging being some of them. But two that I'm going to emphasize are importance of volume assessment and correction, and role of computerization, 3D imaging, modeling, and navigation, and the patient-specific implants, which have made another increased our armamentarium and made a new methodology available to us. So when you have an orbital defect, it is important to assess well what the altered anatomy is, carry out a 3D imaging and modeling, assess what the orbital volume change has been, and choose the appropriate correction in specific cases, patient-specific implants, and we'll emphasize this well when we talk about where they are indicated, and make sure that you assess what happens at the end with regard to the volume. So this is now a much greater realization that restoration of precise anatomy, precise volume is critical, and therefore the DICOM images, as was emphasized in films, with the coronal and sagittal views besides 3D reconstructions being important for our assessment. And DICOM standards have ensured that we communicate much better, we see much better the data with regard to the imaging. And this allows us to do 3D printing and modeling, which gives us a much better preoperative assessment and planning. Quantitative assessment of orbital volume is now markedly improved because you do surface rendering assisted region of interest computation. After identifying the landmarks, use the readily available softwares now for orbital volume calculation. And you can see if there is an altered volume as in the right orbit here, as compared to the left, you can try and restore it back to the volume that the left has. So the patient-specific implants are designed based on the 3D printing and modeling, and the vendor will prepare the implant design and send it to you, including the holes, including the positions, and you have to modify it according to your clinical assessment. Because what is true for a bone model is not always so easy for a tissue with soft tissues present with other landmarks which you do not want to disturb. So there are specific indications where you need to use PSIs. There would be cases like this, like the white-eyed fractures we spoke about, where we would simply release the incarcerated contents and put in some kind of a soft implant, possibly resorbable implant. If there is a larger buckling incarceration of contents like this, we would do removal of the incarcerated contents by a hand-over-hand maneuver, see the edges of the lesion, and then go ahead with an implantation of an implant which will cover all the edges well, and that is all that you would require. This could be a EPTFE or a MedPOR implant or any other implant which is adequate to cover that area. But when you have large fractures with big downward displacement of contents, combined floor and medial wall fractures, especially if the infromedial strut has been affected, then it is important to have titanium implants which will provide that kind of support to the floor and to the medial strut, and to have the right angulation, as Ganga stressed so well, is very important in order to get the appropriate result. But other than these, there are those cases which are large fractures, multiple fractures, old fractures, near total loss of floor, previous failed attempts, where any corrective surgery would require a reopening up, probably refracturing, and then doing a much more complex job which may not work well. And in these cases, patient-specific implants do well. Like this patient with severe enophthalmos had an old orbital floor fracture, medial wall fracture, lateral wall ZMC fracture, and here we thought of a patient-specific polyether ether ketone implant on a model. Then we did you need to do in these cases a very wide opening up of the periosteum and the periorbital lifting across a large area in order to accommodate these patient-specific implants, fixate them well. Here we also did a lateral canthal disinsertion and reattachment, and we could improve the enophthalmos very significantly. This lady had gross enophthalmos as a result of her fractures, multiple fractures, and she had a dermis-lined socket. We could see the alteration in the orbital volume because of the displacements of the orbital walls, and we planned a patient-specific implant of titanium which was placed, and we could improve her socket to a large extent, improving the appearance of enophthalmos very, very significantly in this patient. You can see the much better appearance of the supratarsal sulcus area. This patient is a particularly important situation where there has been a maxillectomy and ethmoidectomy following mucormycosis with very significant enophthalmos, downward displacement of globe, and we can see the large defect that exists for ethmoid and maxilla, resulting in this displacement. Here we did a patient-specific PEEP implant for the floor with a titanium implant for the medial wall, and we could get a much better position of the globe, much improved enophthalmos, and a much more normal-looking motility. So 3D printing and patient-specific implants allow mirroring of the fellow orbit, a better preoperative planning to allow complete walling of defects to match the contour and precise volume restoration. PEEK is an important material because it shows good biocompatibility, is visible on radiology, and has good manufacturing processes and mechanical properties. The limitations include the need for more advanced technology, higher cost, and limitation of soft tissues to accommodate implant material. Last thing, the complications. Now, this patient was done together with a plastic surgeon who also did a bone graft for the maxillectomy for a mucor excision. Here, this is the patient-specific implant put in, but he developed an exposure in this region which could not be corrected in spite of repeated efforts, and we had to remove the thing. So we have to be cautious also in these materials, but this is the only one in 19 cases that we've had a difficulty with. So you need to be cautious, you need to take care of all these issues as well. So 3D modeling, volume assessment, and patient-specific implants are a major advancement and addition to our armamentarium. in appropriate cases. So newer developments like these promise an exciting future for orbital fracture management. Thank you.
Thank you. Thank you so much, sir, for that lucid lecture on the patient-specific implant. One quick comment from Dr. Ganga before proceeding to the next talk. So next, I'd request Dr. Senthil Nathan for his talk on management of complications of orbital fracture repair. Dr. Senthil is a past executive member of OPAI and presently the consultant oculoplastic surgeon at Ramana Eye Center at Chennai. Over to you, Dr. Senthil.
Yeah, thank you. I'd also like to thank AIOS and Dr. Fairuz for this lovely opportunity. Thank you. And today I'm going to speak to you on orbital complications of orbital floor fractures. And as we all know, there's a lot of interest in managing these fractures among oculoplastic surgeons, which was not there a few decades back. And so we also need to know what are the common complications and how to manage them. And we all know there are a lot of factors for a successful outcome, when to operate and whether to operate or not, what choice of implant, how to approach and all that. And it's not very uncommon to see complications nowadays with the increasing number of surgeries that are being performed. And you can basically divide them into intraoperative and postoperative complications. So in intraoperative complications, you have a wide variety. And I'll just quickly go through each one of it. And lid avulsion is one such complication. Sometimes, like what Dr. Raghu was saying, you need to operate with facial-maxillary surgeons and surgeons from other specialties who are used to giving good traction. And when you're operating around the eyes, transcranial approach, when you handling the lid, and if you're not careful, if you don't warn them, you can actually have a lid avulsion, you can cause damage. And this is one such person who had a avulsed lower lid, and we had to repair the lid. And corneal abrasion, again, very, very common complication, especially if you are operating with facial-maxillary surgeons. They don't know the importance of the cornea. And very, very commonly, you'll find the patient have an abrasion at the end of the surgery, which actually is a very serious complication. And again, exocular muscle damage, iatrogenic damage. You have patients who come with entrapped muscles, medial rectors, inferior rectors, entrapment. And you have to be careful when you release the muscle from the entrapment, like what Professor Grover is showing in this video. And you can see the muscle is tightly entrapped. Sometimes what you need to do is you need to actually gently enlarge the fracture before you try to yank the muscle out of the fracture. And you can see this patient has got a floor fracture. And sometimes if it's a trapdoor fracture, the muscle is tightly entrapped, and you need to slightly enlarge it before you release the muscle. Otherwise, you can cause permanent damage to the muscle. And these are a wide variety of implants which we knew how the transition was there. Initially, we had these sort of titanium meshes which used to cut, and then we had the preformed implants with the plates which you can anchor it, and now we have the contoured implants, the combined medial and lateral wall. And so the implants are getting better and better. But if you're not careful about the plane where you place it, you can have complications. This is one such patient. You can see the implant right into the orbit itself, and she had a difficult elevation even after the surgery because the implant was right into the orbit over the inferior rectus. This was one such patient whom I had to handle recently. You can see she's been already operated, but you can see the outcome cosmetically is not acceptable. She's got a low eyelid retraction, a lag of thalamus, and enophthalmos. What actually happened is she had a very trivial fracture while she was holding elsewhere. You can see the pre-op scan. She's got a very small fracture in the floor, no entrapment, no diplopia, but she was advised surgery, and the surgeon went ahead and operated. You can see after the surgery, you can see the plane of the implant is not in the right plane. It's actually intraorbital. You can see the zygomaticotemporal fracture has actually not been plated, and even the plate in the frontozygomatic region is broken. So we had to actually go and reoperate this patient because she had difficulty in opening the mouth as well. And first what we did was we had to take off the broken plate, and we had to put in new plates. Sorry. And following that, we had to again reopen the initial incision. What she actually had was a lid retraction, which was causing a lot of discomfort. And that was because during closure, if you're not careful about the closure, you can have a posterior lamellar contraction and you can have a lid retraction. So what we did was we went to the same transcranial incision. We removed the old titanium plate, which was in the wrong position. And this is the most important part, which I want all of you to carefully note. The implant is actually not subperiosteal, so that's very, very important. your implant should be subperiosteal as much as possible. If it is over the periosteum, it will go right into the orbit, and you'll have incarceration of the recti muscles and the intraocular contents into the implant, which will cause a lot of problems like diplopia. You can see that is the periosteum, and the implant actually should have been underneath the periosteum. So when you dissect, just be cognizant of this fact. Try to place the implant underneath the periosteum, which will save you a lot of trouble. And following this, actually what we had to do is we had to place a hard palate graft. We harvested a hard palate graft for the low eyelid retraction. And we had to place it to correct the low eyelid retraction. And you can see post-operatively, there's a significant improvement in the low eyelid retraction and cosmetically much better now. And post-operative, you can have a lot of complications, wound-related, mainly implant-related. And it's very important for you to note, don't make an incision like this. Always try to go subciliary or transconjunctival. Don't make an intraocular incision, or you can get chronic lymphedema. Also ask for history of keloid formations. And like I said, implant, very important for you to anchor the implant properly. Otherwise, you can see this is an old silicone implant. You can see the implant is almost into the maxillary sinus. So you have good implants now with rigid fixation. And these can be fixed to the orbital walls, and you have the combined Medport titanium, which is one of my favorite. So you have the advantage of the titanium along with Medport, and you can also fix it. And you have good microplating systems with which you can fix. This was one such patient who actually had an implant migration. It was operated by a facial surgeon who had, and he put in a combined rib cartilage and a bone graft. And this patient had a lot of pain after the surgery, was not able to depress the eye, and that's because when you do MRI, you can actually see the rib cartilage indenting on the inferior part of the globe. And so what we did was we actually went ahead and we had to actually take off that implant. And you can see when you try to take off the implant, you can see the rib cartilage. What has actually happened is the rib cartilage has gone back to its original shape. So when they put in the implant, they do what's called scoring. They make it flat. But because of the memory of the implant, it again goes back to its original shape. And this was the reason the patient had so much problem. You can see it's gone to the shape of the rib, just poking the eye and causing a lot of issues for the patient. And once we remove the implant, we can see the globe has come back to the normal position, and his problems were resolved. Implant infection is not at all uncommon. If it gets infected, it's a major issue. You need to do an implant exchange. And this is an example of a Medport implant. Be very careful when you use Medport. It's very porous. The surface is very, very abrasive. If you don't do a proper closure, you can have exposure. And then you have only option is you have to take the implant out. Again, when do you operate? It's ideal you operate very early. If you have a patient with an entrap muscle, don't wait for too long. Intervene and operate early. Otherwise, even if you do a good job and release the entrap muscle, if you operate it very late, there'll be permanent damage and the patient will be left with persistent diplopia. This is one such patient whom I operated very late because he referred late, almost 1.5 months after surgery. You can see intraoperatively, I was very sure I'd released all the incarcerated muscles and the implant was in the correct position. But post-op, his elevation did not improve at all because we had intervened too late. And you can see post-op, the implant is in the correct position, the muscle is not entrapped, but yet the patient has got diplopia. This was one more interesting patient, already 3 times operated with NLD obstruction when he came to me. First time was operated by a facial surgeon, but did not put a floor implant. Second time, oculoplastic surgeon did it, and he did it under navigation control, did a good job, but unfortunately the implant got infected. And so third time when he came, he had an NLD obstruction, and what we did was, just a few more seconds. What we did was we had to take off the implant again, which was in the wrong position. So if it's not subperiosteal, you'll have problems. So if it's supraperiosteal, be sure that the patient is going to have a lot of issues. So what we did was we had to take off the implant and then we had to do a DCR as well. And you can see following that, the patient resolved very well. All his complaints were a lot better. And in ophthalmos, again, is common if you don't place the right implant. You have good implants like what Professor Grover is saying. And you can get very good results if you place the right implant. One of my last slides, all these patients ask them not to blow their nose because you have a connection from the sinus to the orbit. If the patient blows the nose before or after surgery, they will end up with orbital emphysema. So to conclude, complications are not at all uncommon. Everybody gets them, but if you tackle them with a calm and cool mind, be sure you'll have success. Thank you.
Our next speaker is Dr. Maya. She has been coordinating and moderating this meeting with a lot of elan. Now it's our chance to hear some pearls of wisdom from her. The floor is yours, Dr. Maya.
Thank you, sir. Thank you, AIOS Scientific Committee, for this opportunity. So I've been asked to talk about periocular soft tissue trauma, no financial disclosures to make, and I'll be covering canalicular laceration repair, lid lacerations, and few case scenarios, including foreign body hematoma and globe luxation management. So the key steps in canalicular tear repair is find the torn ends of the canaliculi, temporarily place a well-tolerated stent, and then do an accurate layered closure of the lid laceration. So this was a case of post-road traffic accident, both upper and lower lid laceration, along with both upper and lower canalicular were lacerated. So first and foremost, it's important to debride all the necrotic edges and clean the wound, and then locate the punctum, dilate it, and then pass the probe. And it's most important to locate the distal cut end of the canaliculus. So here it was a very proximal injury, so it was not difficult to locate under high magnification of the microscope. And here I'm using the stent that is a monocanalicular self-retaining silicone stent, and the length is approximate 40 millimeters, so we can trim it a little bit. And then the collar, it snugly fits into the punctum, and then you can just bevel the edge and then put it into the distal cut end of the canaliculus. And it goes very well. And then very importantly, you have to reapproximate the pericanalicular tissue, taking care not to take the bite from the canalicular wall. And here I'm using 6-0 vicryl suture, and then do a layered closure. And here, because we were having multiple lid marginal lacerations, so some tension, some stress was there on the margin, but doing a layered closure. And then upper canaliculus I was not expecting, and we were not having another stent. So here I've used a silicone rod that we use for ptosis repair. So that also can be a substitute for stent in these cases. So although the diameter is a little bit more than, and that it's not that flexible, but, and then again, it doesn't have the collar, and you have to secure it within your skin suture. But, and the other thing is that, shall we repair the upper canaliculus? So yes, whenever possible, you should do the upper canaliculus repair also. So here you can see very snugly fit collar of the canalicular stent, and when to remove it, around 6 to 8 weeks post-op, you can remove it, because we know that a biofilm gets formed after that, and we don't want that to be. And sometimes you can use a pediatric intracath IV cannula when you don't have any stent material or silicone rod available at your OT. Sometimes the canalicular cut end is very distal and difficult to find, like was there in this case. So people have advised to use pigtail probe, but I usually don't prefer to, do the instrumentation through the uninjured canaliculus. So here I have injected some colored fluid. You can use methylene blue or any dye, and then it will help you to locate from where the dye is coming, and then you can very well locate the distal cut end, or you can trace it just beneath the medial canthal tendon. There you will find it. And again, finding the cut end and cannulating it with the canalicular stent and approximating the tissues. So reapproximation is a key to get a good result. Basic principle of lid laceration repair is always place a suture so that the skin edges remain slightly puckered or pouting, so that the depressed scar does not form. And whenever you are placing the lid marginal suture, the ends can be kept long to avoid the corneal irritation. Whenever there are deeper laceration, look for any levator aponeurosis injury and reinsert it into the tarsus. Never suture a septum, because you may lead into the leg of thalamus. Medial canthal repair needs to be done very meticulously, and if you don't find the proximal cut end, then you can just suture it with the periosteum in the region of nasomaxillary suture posteriorly. Discussing few case scenarios, this was a 30-year-old female. She presented to us with a purulent discharge from the right eye after a trauma to the wooden stick 4 months back. However, no entry wound was visible, In the MRI, you can see hypo-intense, this linear intensity, superiorly, superolaterally in the orbit. And when I traced from the superior fornix, this linear intensity was a wooden foreign body. Yet another case of a similar presentation, she was treated as acute dacryocystitis. However, on careful history, there was a history of fallen shrub 3 months back, and we located multiple wooden foreign bodies that were there in the orbital apex going into the infratemporal fossa. And through the inferior orbitotomy approach, we were able to retrieve multiple pieces of wooden foreign bodies through the inferotemporal fissure. Around 12 pieces of foreign bodies were removed. So always in cases of post-traumatic persistent inflammation or discharging sinus, you should have a high index of suspicion for retained intraorbital foreign bodies. This was a patient, 7-year-old male, who presented to us after a fall from height with a traumatic luxation of the globe. And the key for successful management is early intervention, do a temporary tarsorrhaphy. If you are finding difficulty, do a lateral canthotomy or cantholysis and mobilize the lid, and the globe will be pushed back into the orbit. Now, this patient presented to us with the downward displacement of the globe after a fall from bike, and you can see a very you can see the CT scan is showing this hypodense collection in the superior orbit, the boat-shaped convexity. And as an OPD or a minor OT procedure, you can just do a needle aspiration of these subperiosteal hematomas. And on table, you will see that the proptosis will be relieved. And this patient was also having RAPD, which disappeared, and the vision was improved after the aspiration of the hematoma. So to conclude, I'll say that individualized approach and sound knowledge of clinico-radiological features help in maximizing the outcomes in periocular trauma management. And I've just shown the video in the interest of general ophthalmologists, because not always they have an oculoplastic surgeon nearby to refer the canalicular tear cases. And I think they should also attempt these canalicular tear repairs with the stent. Thank you very much.
Thank you, Dr. Maya. Very relevant discussion. And you can now keep on moderating.
So,
Maya, excellent. So just one simple, in case of an insurance patient or in a government setup, if you are expecting only one canalicular injury, both are proximal, then in such cases the other end, long end, very long generally, that one you can use. Because in a proximal end, so long, the tube is not required most of the time.
Yes.
So up to the sac, you can assess, implant one, and the rest of the thing you can utilize in the other.
Definitely, definitely. So the same stent you can use for both the canaliculars. Yes, we don't need that long,
No,
right?
that if you use other, that one may, biofilm may develop, or there may be a size in case of especially in case of a pediatric case may varies.
Okay,
So that's
thank you.
another observation.
Yes. So the last talk of the session, we have Dr. Akruti Desai, and she'll be presenting a case of orbital trauma, globe interception, and she has been an ex-fellow of LV Prasad Eye Institute and presently working at Shantilal Sanghvi Eye Institute. Over to you, Dr. Akruti.
Good afternoon, everybody. It's a pleasure to be here back in Calcutta after 8 years. So my case is of orbital trauma of globe interception. I'll come to why it was called that way. So there was this 17-year-old girl who presented with a bullhorn injury, of a day-old injury, trauma with a bull's horn 1 day prior, came to the clinic in the evening. Her visual acuity in the right eye was 20/20. She said there was sudden painful loss of vision. She didn't know what exactly had happened. There was no perception of light in the left eye. There was no globe visible. Severe conjunctival chemosis, hemorrhage, and a small eyelid laceration on the upper eyelid. So as you can see, when we open up the eyelids, just a socket was seen with conjunctival chemosis and subconjunctival hemorrhage. So the resident who was present suspected either it is traumatic enucleation or an ophthalmic socket. On imaging, it was seen that there was globe seen in the left maxillary sinus. The trauma must have been severe enough to cause such severe globe dislocation in the maxillary sinus. There was a large floor fracture with loss of inferomedial strut, like Dr. Ganga and Dr. Grover have beautifully presented orbital fractures. So without the loss of the inferomedial strut, it's not possible for the globe to completely dislocate into the maxillary sinus. Intraoperative, this is an intraoperative picture where deep into the socket, the cornea is barely visible. The surgical technique that we followed, there are multiple, either transconjunctival, subciliary, and caldoveil, all three techniques have been described in literature. And since it's not very common, there are limited cases which have been reported. So the technique that we followed was a caldoveil procedure, wherein an opening was made just lateral to the pyriform fossa, up to the lateral end of the maxillary sinus, and just below the inferior, the upper edge was just below the infraorbital canal. Care has to be taken that the inferior edge has to be above the root of the canine tooth. The anterior wall is gently removed, and the globe is gently pushed so that it is at least visible through the orbital socket. A transconjunctival peritomy 360 degrees was done. Fortunately, all muscles were intact, and they were hooked to ensure that the globe can be retrieved easily. Floor implant, a rigid floor implant of titanium 3D was implanted just below the periosteum, and the oral cavity wound was closed. This was her immediate post-operative picture where there is still some subconjunctival hemorrhage, but you can see the globe in the orbital socket. And 2 months later, it looked much better, but her visual acuity remained no perception of light because there was probably a 2-day delay and there was severe trauma causing dislocation of the globe in the sinus. This is a fundus photograph. In the immediate post-operative period, there were retinal hemorrhages and there was generalized retinal whitening. And 2 months post-operative, there was complete optic disc pallor with sclerosis of vessels and pigmentary changes at the macula. So coming to the discussion, there is just not the loss of floor, because there have been cases where there is loss of the maxilla along with the floor, but it does not cause complete dislocation of the orbit. So definitely when there's a forceful trauma, there is a disruption of the ligaments, the bulbar fascia, the orbital fat prolapse, and the globe can telescope it through the conjunctiva into the maxillary sinus. Why is it called intersusception is, as we are aware, in acute obstruction of the intestine, there is telescoping of the intestines causing blockage of the distal end of the intestines. Whereas here, with a forceful trauma, the globe is telescoping through the conjunctiva into the maxillary sinus. So if you consider the anterior edge of the telescope to be the bony wall, the one beneath as the conjunctiva, then the tenons, and then the globe. So that kind of helps us understand the mechanism by which the globe might be telescoping into the maxilla. A review of literature was performed, I did from 1971 to 2020, looking for terms like traumatic globe dislocation and maxillary sinus, and we found that there were 24 cases, similar such cases reported. Although maxillary sinus is more common, it has also been reported into the ethmoid sinus as well. More than 50% of these cases are due to road traffic accidents. There was just one case previously reported which was due to a bullhorn injury. In the outcomes, about 33%, 33.33, recovered some amount of functional vision, and 5 of them were reposited on the same day, whereas the other 4, the time duration from the trauma to the reposition has not been reported. Not been mentioned in the papers. So to summarize, intersusception of the globe can be misdiagnosed as anophthalmic socket or autoevisceration. There are 2 techniques, either direct traction by subconjunctival or subciliary approach, or transmaxillary approach. Reconstruction of the floor needs to be done by a suitable rigid implant to prevent a late dislocation again into the maxilla. And irreversible vision loss, as coroner has mentioned, is due to either direct trauma to the optic nerve or twisting and stretching of the central retinal artery when the trauma has occurred. The choice of approach, we feel, should be guided by the proportion of dislocation as demonstrated in the CT scan. If it is more superficial, just a transconjunctival approach would be possible, subciliary approach could be, transconjunctival approach either with a peritomy or a direct transconjunctival approach would be possible to retrieve the globe. But if it is deep into the maxilla, then a supportive cadwell duct might be beneficial in retrieving the globe. So we would recommend 360-degree peritomy with suture tagging of extraocular muscles, which can ensure safe repositioning into the orbit with intact extraocular muscles, because when you're going blindly into a balloon conjunctiva, you may traumatize the globe as well while trying to tag the muscles. Thank you very much.
Thank you, Dr. Akruti, for that wonderful case, wonderfully managed. And because we are running very late, 20 minutes late, so we have to wind up the session. And if the audience have any question, they can approach the speaker directly off the dais. I would request Dr. Fairuz to invite for the next session.
Thank you, Dr. Maya, and thank you, the dignitaries on the dais, for making this session amazing. And well, excellent case. It was so nice. Yeah, thank you so very much. Because of the paucity of the time, we're going to switch to the next session.
Yeah.
Thank you
I would
so
request
much.
all the panelists in chairs to come upon the dais for a group photo. Can we have?
Do you want to take it down? So